Annuloplasty rings are also frequently used in mitral valve repair surgeries. They help because they restore annular physiologic size and geometry, they can enhance leaflet coaptation, and they can also prevent further annular dilation for more durable repair surgery. How do surgeons size these rings? Well, the two main factors that determine sizing of these rings include measuring the intertrigonal distance, that is the distance at the top, horizontally left and right between the two trigones, and also the anterior mitral leaflet height. That anterior mitral leaflet height matters because a surgeon needs to allow that anterior leaflet to spread all the way out and coapt on the correct plane at the correct coaptation line without prolapsing. If the ring is sized too small, that can increase the risk of SAM because you're moving that posterior part of the annulus more anteriorly. You're closing that gap between the interventricular septum and that coaptation point. Also, if the ring's too small, there's increased risk of ring dehiscence because there could be too much tension on that annular site. If the ring is too big, well, it increases the risk of residual MR. In type 2 Carpentier lesions with excessive leaflet motion, prolapse leaflets, flail leaflets, the strategy here is sizing correctly or relative upsizing of the annulus. That's because you're trying to get a ring that matches the enlarged annulus that can accommodate a lot of that excessive leaflet tissue. However, in the Carpentier type 1 or 3B lesions, there's a dilated annulus, and that's a big reason why there's MR in the first place. So if it can be downsized with a complete annuloplasty ring, the hope is that doing so can downsize and improve the coaptation length of the valve and actually improve the MR altogether. How does a surgeon even decide what type of ring or band, flexible or rigid, partial or complete? How do they even decide what they're going to put on a valve? Well, frankly, a lot of this is based on surgeon preference. There's a few principles to remember. When deciding between a flexible and a rigid band or ring, the advantage of the flexible one is that it preserves the natural dynamic annular motion. The advantage of the rigid one is that it can restore the annulus to the natural saddle shape. When thinking between partial or complete bands or rings, the partial one can be favored in myxomatous valve disease, as it's more common that the posterior annulus is prone to dilate in these patients. So you don't need something on the anterior portion of the mitral valve as well. And the fix purely requires a stable annulus. However, a complete ring may be favored in secondary MR patients where the anterior annulus can be prone to dilate more. And to actually fix that valve pathology, a smaller annulus is needed, so a complete ring can help create that smaller downsized annulus.